see, especially in primary care, emergency room. Okay? Chronic, bacterial, viral, allergic. You can get chemical irritant. You can have dry eyes that causes a conjunctival irritation, remember conjunctivitis inflammation. You need to figure out if it's just the conjunctiva. So this is what you need to make sure you really think about. Conjunctivitis does not hurt. It does not cause blurred vision, meaning it doesn't cause change in your visual acuity. They may say they have blurred vision, but I blink and it clears up. And you check their visual acuity and it's their normal visual acuity, right? It's not painful. It may be irritated, but it's not painful. So a red eye that's not painful and normal vision is a good thing. A red eye that hurts and has change in vision is a bad thing. And you have to figure out what it is. Okay, so newborn conjunctivitis. This is important. Okay? The first day is reactive to what you put in. A newborn gets erythromycin ointment put in right now. Okay? It protects them from getting other types of conjunctivitis as they went through the birth canal that they can get from their mother, like gonorrhea and chlamydia, which is an STD. So they put erythromycin ointment on right away, and that first day they'll get red eyes because they kind of have a reaction. Some babies have to erythromycin. If you get a conjunctivitis 2 to 4 days later, you better think gonorrhea. And gonorrhea, as with gonorrhea coming out of the vagina, as with it coming out the penis, is nasty. It's green. It's lots. It's ugh, okay? Why do I want you to know this? Because I want you to remember gonorrhea has lots of discharge. From the eye, from the vagina, from the penis. Chlamydia. Usually you see it a little bit later, 5 to 12 days. Okay? But as with chlamydia in men, they usually don't have any symptoms, so they have scant discharge. Scant means really big. Women tend to not have as much discharge either. So you can remember. It's usually kind of a yellowish discharge, less. But they have a conjunctivitis at that date. Okay? Now you know about STDs. You can treat. So here's a newborn conjunctivitis. We don't see much of it anymore because we treat it pretty quickly, but it still doesn't mean it can't happen.
So the yellow is going to be the chlamydia, all these newborns, or?
It's going to be by date.
Oh, yeah.
Yep. But the discharge can give you an idea. And also what's going to tell you is you're going to, anytime you find purulent draining stuff, what are you going to do? You're going to culture it. You're definitely going to culture it in a newborn. Because as they come out the vaginal canal, they can get some really bad stuff. And a conjunctivitis in a newborn is treated with antibiotics systemically, okay? Because they get really sick. They can get pneumonias from chlamydia. They can get really, really sick. So that's why you want to know exactly what you're treating. Versus you, when you get a conjunctivitis, we just throw antibiotic drops at you and go for it. So bacterial conjunctivitis. How do we know the difference between bacterial conjunctivitis and viral conjunctivitis when you come see me? Go ahead.
Fever?
Is it purulent?
Yeah, purulent, drainage, yellow, green, thick discharge versus viral, which is less. I don't see viral conjunctivitis very often, but we treat it like it. red eye, lot of crusting. They wake up in the morning and have to, use a wet wash rag to open their eyes. Here's a pink eye, right? Pink eye, or conjunctivitis. That's not a diagnosis, pink eye, it's conjunctivitis now, you're adults, you're PAs, some point. Treatment, go with Dr. Latassi's. There's lots out there, right? Lots out there. Let me make sure I told you something. Hold on. Oh. I highlighted and I underlined something that's very important. Most common identifiable cause of neonatal conjunctivitis. I would probably know that if I did that. Like I'm pretty sure that's a test question that I would write. It's not oh, well, then put a star by your computer PowerPoint thing. Newborn, chlamydia is the most common. The second most common is gonorrhea. Did you get that? Are you sure? Because if you get that question wrong, I'm going to be. Right, talk about this, talk about that. Adults can get gonorrhea, conjunctivitis. They can get chlamydia, conjunctivitis, and I don't have to tell you how they got that right. I don't have to tell you physiologically the mechanism of how they got that.
How is it?
No. I'm not demonstrating.
What did you tell us actually?
Now, you can also get Reiter's syndrome, which is an infection with STDs, mainly gonorrhea, that you have an STD, you have burning with urination, you have joint pain, and you have a conjunctivitis. Okay? But that's not the gonococcal conjunctivitis that I'm talking about right now. Okay?
So it says it may involve the cornea, and so how does that happen? Because the conjunctiva attaches and kind of separates.
Right, it spreads. So it goes from remember the conjunctiva goes right up to the cornea, and then it actually goes deep into the cornea. Yeah. So that's why it's an emergency. You send it to the ophthalmologist. Because, as you see, it's not only topical antibiotic. We treat with Rocephin, which is the treatment for when you have vaginal or penile discharge and you have gonorrhea. We use 250 an IM injection into your buttocks. But if you have conjunctivitis, we use actually 1 gram, so it's a bigger shot. Okay, so it's a lot bigger deal. We treat it.
This is hypothetical, but if we saw someone in the emergency department with this and we knew that they weren't going to be able to go to an ophthalmologist, say they didn't have health insurance, how would you go about treating that? Without their intervention, can it be taken care of?
Well, you could start treatment, but it's your job to actually find an ophthalmologist. And usually in an ER, you can find, this is what you would do. Insurance isn't your issue. Your issue, it is your issue, meaning that you have to call and find an ophthalmologist that they can see this patient. Okay? Just because they don't have insurance, you still have to find treatment for them. And there are people that see these patients, that take patients without insurance. So that's part of the problem that we still have. But you can do the treatment. You can treat treat them with Rocephin and Zithromax to cover both gonorrhea and chlamydia. You can start them on eye drops, but you just want to refer because they need to do a slit lamp to make sure that it hasn't progressed. Most ERs don't. Or they do, they don't know how to use it. Some do. This is chlamydial conjunctivitis, viral conjunctivitis. Probably 90% of what we see conjunctivitis, but in America we treat viral conjunctivitis with eye drops because kids have to go back to daycare and 24 to 48 hours. Supposedly they're not contagious with their bacterial conjunctivitis on eye drops, but it's viral most of the time. So my point is, we treat most viral conjunctivitis with antibiotic drops. For a test question, for boards, for a test question, not what I just said for clinical. If you were given a person with photophobia, red eye, watery discharge, but no kind of allergy symptoms, but had URI symptoms, because they usually have a URI, a cold, sore throat, cough, congestion maybe, and they had, this watery discharge and red eye, what would be your treatment for the eye on a test? I think it's viral, right? You can treat it, it's a virus. Doesn't need antibiotics. You would fit conservative treatment. No antibiotic drops indicated. Because viral conjunctivitis usually goes along with the virus, right? Measles is a virus. They have red eyes, they get a conjunctivitis with it. Most of all the things we immunize nowadays is a virus, and they get a pink eye with it.
So we're using the eye drops for the bacteria?
We're using it because mom wants the kid to go back to daycare, and they can only go back to daycare if they've been on the drops for 24 hours. So we're playing a daycare game, or a school to get them back into school. Even though their conjunctivitis is going to last 7 to 10 days, and they're been on drops. And they're still spreading it to everyone in school for the next 7 to 10 days.
So that gives them no alleviation. It's just for oops.
It's soothing to mother and father, and making the school very, very happy that they're on drops, even though we're not doing anything. So that's a clinical thing. That has nothing to do with boards or tests. But just wait, you'll have to deal with it. Drives me crazy. Okay, allergic conjunctivitis. This is someone who has, they don't have much discharge from the eye. Okay, it's the string. Yeah, kind of wipe it, and kind of, it's stringy. Redness, tearing. If you pull down the eyelid, okay, you can see cobblestoning on the tarsal conjunctiva, okay, inner side of the eyelid. They have a history of allergies, you ask them. The medications, Dr. Latassi, but she'll tell you all these. There's really classic allergy drops out there. Too fast? Okay. Pterygium and panguicula and conjunctival hemorrhage. Okay, these are on the conjunctiva still. Pterygium. You guys have seen this, it's really common in Oklahoma because we are a huge allergy state. We're always within the top 5 for high allergens, cedar, all that kind of stuff. But you get a fleshy colored tissue growing over, and you usually see it, you can see it both, on the temporal side or the nasal side. But when I show you the picture, you're gonna know exactly what this is. You've probably seen this on people, okay? What do we do for it? It's not treatable, it's not preventable. They usually have a history of allergies. We see it a lot in people that work outside. And we don't treat it unless it grows over the cornea, or it starts to encroach on the cornea and over the pupil area. Okay? Because it affects your visual field. Okay? Sometimes they will try topical steroids, but we cannot prescribe topical steroids unless we work for an ophthalmologist. I've never prescribed them ever. Pinguicula, it's a raised yellow, fleshy tissue that grows on the eye. It's not a bad thing. It doesn't say that you think of any disease, but I just want you to be able to understand what it is. We've seen these on eyes. Okay.
Is that an allergy response too? No.
Yeah, it's not a response to anything that we know of. We don't know really the etiology of it. That's a really severe pterygium. I've never really seen one that bad. I've seen it kind of come just onto the cornea, but I've never seen it that significant one. Subconjunctival hemorrhage. I would bet a lot of you have had this at some point. This picture usually, most commonly, I see this a lot in college kids, I was just a test, and I was a drinking, partying, I probably had too much to drink, and yeah, I was thrown up last night quite a few times. And I woke up and they've got subconjunctival hemorrhages, because what happens is the superficial blood vessels of the conjunctiva rupture. Or you see it with any type of Valsalva. You can see it with Valsalva straining, right? See it with wrestling. You see it a lot anytime you're kind of exerting some pressure. What you really want to think about is if someone has a history, or you tell me you have high blood pressure, I want to see which blood pressure is, because if it's really, really high, we may have something going on. Or do I have someone with bleeding disorders, like a bleeder? Or they're on blood thinners and their blood is too thin. I better check that. But I see this all the time, and people come in and they are freaked out because they think, oh my gosh, because it looks terrible. Sneezing can do it. And they come in usually like that, because they don't come in with a little one. They come in like this, and they are brutal. But this is what you want to look for. There is nothing in this anterior part of the eye. There is nothing behind the cornea or in front of the iris. That's the most important thing. When you look at this, you look here, you make sure there is no blood in that anterior part of the eye, okay? To the cornea. Foreign bodies. Common. They'll come in, got something in my eye. If you have to ask the history, were they working with metal? Do they think it's metal? If it's metal, and you find it, you remove it, but you also have to kind of rotor around it, because you'll get a rust ring. Just like if metal stays in an area that's wet, it rusts, right? And it'll spread the rust. So usually I don't have the ability to do that in my office, so I have to send them to the ophthalmologist. Because you kind of drill all the way around it and make sure you've got rid of all the remnants of that piece of metal.
Well, we learned how to do that here. I've seen it, but like I've seen a PA do it, and I don't know if she just learned it.
Probably, depending on if she had the tool and where she was at. Usually in, like out in rural Oklahoma, they have them, because ERs have them a lot. So, especially if it's over the cornea, you want to follow it, because if it's over the cornea, we can lose sight. So if you scratch it, because whatever's there has scratched it, has put an irritation there, you want to follow it every 24 hours, because you want to make sure that that scratch, or that little tiny puncture into that conjunctiva, or cornea now, the cornea, because you can have an abrasion over, or a foreign body stuck here. But if it's in this area, you remove it, and then you want to make sure that heals up. So you just pop it out with the 18 gauge. Just take the edge of it and pop it out. And you start them on antibiotics, and then you follow it. Yeah.
How many days do you want to follow it? If you want to see them every 24 hours, for how long?
So I want to look the next day and make sure it's getting smaller. And then usually it's healed up in 24 to 48 hours. After that, they're fine. So foreign body corneal abrasion. Foreign body causes corneal abrasion when it does. Same thing. So I can get a foreign body, or I can scratch it. Right? I can scratch my cornea. I get something, grass flies in there, I start rubbing at it, and I scratch my cornea. Most common cause, right here, contact lenses. So these hurt. Corneal abrasions hurt. They hurt. They hurt. Did you get it? Okay. They're red, eyes red. They can't, the lights bother them. Like, oh my God, they're in the room doing this. So they get photophobia. They feel like something's in the eye, but when you stain the eye, you don't see anything in there, but you actually see the uptake of the fluorescein stain. When I drop in the topical anesthetic, it goes away. They just think I cured them. They wish I could give it to them all the time.
Does it reoccur?
The abrasion? Or does the pain come back? What do you mean? What's your question?
The abrasion, after you put the topical drops, does it come?
Yeah, the abrasion's still there, but what I've done is I've numbed the eye, so they don't have that sensation anymore. But that comes back pretty quickly as soon as the medicine wears off. So the complications of this is, if that abrasion doesn't heal, it can get infected, it can get deeper, and I can ruin the cornea. You can get a corneal ulcer. And then I lose my vision. Also, that infection can spread to the iris. Okay? So if I'm at the front part of the anterior, but then it spreads to the iris. Remember the uveitis? The uveitis is infection of the lens, the iris, the whole mechanism that makes makes you dilate, or your pupil change, right? And that's very, very painful. So if you get the infection goes deeper to that middle area, anterior, middle, posterior. So we use topical antibiotics and we recheck it. Should be gone 1 to 2 days. So I put stain in, and it uptakes, and you can see, here's my little corneal abrasion. How do I document this? You always document as a clock. So this is at the 9 o'clock position. Right? You can measure it from the edge of the cornea or the iris, and how many millimeters. And then I can measure the abrasion. It's 1 millimeter. And doesn't cover the pupil at this point, or does. And I know it can change, but you're getting this mainly the same lighting. Or you can draw a picture of it. That's what a lot of people do, draw this, the cornea to the pupil, and mark exactly where it's at and put the size. Because then the next day, if I'm not there, I know if it's changed, they can see if it's changed, or the next day I'm gonna be like, absolutely. Or it's worse, then they're gonna see the ophthalmologist. Corneal ulcer, it's an eye emergency. You call the ophthalmologist now. These people go blind. They go blind. They go blind. I'm not, this is a serious, serious thing. Okay? Again, contacts. You hear this, people sleeping in their contacts overnight and they have a corneal abrasion and then a corneal ulcer. Or they have a corneal ulcer the next day. But it's usually people that sleep in their contacts. Very painful, okay? But it's more painful with the abrasion, and as it progresses to the ulcer, believe it or not, the pain actually decreases. Their vision is poor at this point because it's completely decreased in that eye.
Despite wearing the contact lens?
Because the ulcer is sitting there and it's affecting the field of vision. And the other thing is it's really, we're starting to get a deeper infection. So you're kind of right on the cornea there, but now with the infection, the ulcer is deeper, okay? It's progressed through the epithelium into the stroma, and so it's you can't see. It also, as it progresses, you'll see it's more of a white. This isn't stained. This is just white. You'll see this on people that it's actually scarred now, and they had this before. So you look at their eye and you'll see this. They've had it 10 years ago. So this is much newer. This is much newer. This is a little bit older. But this person hurts. This person hurts. This is an eye emergency. Eye emergency. Don't deal with this. Why does an iritis hurt? Why would an iritis hurt? So the infection progresses, inflammation of the iris hurts. Why would it hurt? And why is it hurting while you're sitting in this room?
Did you focus on
Because there's light and you're moving it. If my finger was infected and I moved it all the time like this, as things are moving in front of my vision, and I'm doing this all the time, it freaking hurts because it's moving all the time. In your eyes, the iris is moving all the time, and I'm moving in front of you, it's contracting, it's dilating, iritis freaking hurts. Does that make sense? Mm-hmm. Now you get it, right? Because you'll remember I say freaking.
It hurts in everybody?
Iritis? Yeah. If you have an iritis, that's a painful eye. Painful eye. That's one of the painful eyes. So I stained it. I didn't, but they stained it in these pictures, and you can see that. Here's just a comparison to look at the two. Okay. Herpes simplex. Keratitis. What's keratitis? It's infection or inflammation of the cornea, okay? That's what that word means. So, if you have a cold sore, if any of you have had a cold sore, that's herpes simplex. Okay? And it comes and it goes. You get it if you're sitting down at the lake drinking beer, because it's a trigger, sun's a trigger. Beer's not. It reflects off your can, and it focuses your sunlight.
So we should drink on
Yes. That's what I'm thinking.
Well, I get it when you have the spring thing too, though.
Stress. So people really pop out with a cold sore when they have stress. Why am I talking about this? Because herpes simplex can also pop up on your eye. Okay? It's not very common, but it can happen. It's the same type of thing. And it's because it's actually on the trigeminal ganglion. So it's triggered by by the same thing, drinking beer on a lake, no. Fever, stress, sunlight, you're studying a lot, you're not eating good. But what this is this is a painful eye, foreign body sensation. They can't see very well. This is on the cornea. Okay, the eyelid's inflamed. But how do I know this is different from anything else that's gone on with a red eye, can't see, blah, 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 blah? Because when I stain it, they have dendrites. Okay, let me show you a picture. So these are dendrites. So the key is I stain it and I see dendrites. This cannot be treated by you. It has to see an ophthalmologist. This causes blindness if not treated correctly. So if you have an eye, you can't figure out what's going, that is red, okay? Painful, decreased vision, usually. But it's pain that doesn't make sense, right? And you stain it, you see something, it doesn't make sense. They need to go see the ophthalmologist. This is oral medication, oral antivirals. Oral antivirals.
So we are allowed to do the fluorescent staining then? That's not something that's unique to
I
ophthalmologists?
do it all the time. You come in, your eye's bothering you, I stain your eye. Right then and there. Just use a black light, put the fluorescent stain in, use a black light. You know, mix neon. Really show up real good. I try not to wear neon when I don't wear neon bras. Okay. Another eye emergency, must see an ophthalmologist. Must. Okay? So, this is a rash, may not even have eye involvement yet, but if anyone gets a blister-like rash right up here, I'm saying this over and over again because if you miss this, they're gonna be blind. Okay? Or you see a blister area over the nose. It's called the Hutchinson sign. It's such a bored test question if I ever heard of that. Signs are always questions. It's questions. Hutchinson sign. If you have a Hutchinson sign, then you have eye involvement. Now, what is herpes zoster? You all, right, most of you, did anyone have chicken pox? Y'all have the chicken pox? Like literally had the chicken pox?
Yeah.
You weren't immunized for it?
I think we were like
Right before that.
Right before?
I got it, I had that shot.
Oh, you're older than I thought then. No. So you have chicken pox, and that chicken pox virus is now dormant in your body. Did you learn this anatomy yet?
Yeah.
Right?
Shingles.
Right, so it's gonna come out as shingles. Well, if it comes out in this area, you have to think that it will go to the eye. So if you get a rash in this area, half to 3/4 of the time, it's gonna go into the eye. So I don't care, you automatically are referring them to see an eye doctor when you diagnose their shingles in this area. Okay?
A very general question, so chickenpox is communicable, but shingles is not?
Correct.
Why is that?
Well, that's not true. Okay? I can't give someone shingles. And I can't give shingles to someone who's been immunized, but I can give that virus to a newborn. I'm shedding the virus at that point, right? So if someone is not immunized for chickenpox, they should not be around someone who has active shingles. So That's not true that it's not communicable. But most people are, I won't give them shingles. What most people say is, can I give shingles? Can you get my shingles? I can't get that. I can't give you shingles. That's not shingles is not communicable, as in to shingles. But it can cause chicken pox. Make sense? Okay. All right, you got it. So there's the rash that you see. That's a pretty severe picture, but the picture I want you to see is the Hutchinson sign. It's on the nose. And it may just be the nose, or just a little bit of redness, because as shingle starts, it's just itching. It's just burning, and it's just a little bit of redness. The vesicles may come up, well, they usually come up later. So I want you to think that in your mind. That's obviously it. As it's crusted over, that zoster is 2 weeks into it. Arcus senilis, we see this all the time. This is normal. This is not an abnormal finding in a patient. We see this in elderly. It's a blue ring around the eye, bluish coloration to white. So you've seen this in older people. Kaiser-Fleischer ring. This is associated with Wilson's disease. That's what you need to know, Wilson's disease, which is buildup of copper because they don't have the ability to break down copper. So copper builds up in the bloodstream and is deposited in the eye. So again, the eye tells us something systemic is going on. Bad thing about this is that it causes mental retardation if it's not picked up early, but we don't see this anymore. It's a picture of it. The sclera. Okay, so sclera. Remember, the sclera is right from the cornea all the way to the back of the eye, right? It's not just what we can see, but it's underneath the conjunctiva. It's deep. Sclera is deep. Scleritis, must see the ophthalmologist. This is a red, painful eye. That's what you need to know too. It's usually related to connective tissue disorder. Like lupus, systemic lupus, rheumatoid arthritis. So if someone comes in with an eye problem, one of the things you're going to ask is, you want to make sure you know their medications, because they may be on steroids because they have an autoimmune disorder or connective tissue disorder. Or those are questions you should ask. Commonly misdiagnosed as a conjunctivitis because it's a red eye. It acts a lot like a red eye. But it's more painful. If not treated, it causes vision loss. And if it progresses to the posterior part of the eye, you can have retinal detachment. Okay. Damage the sclera, the retina can fall off of it. That's what we think about it. Can't miss this one. So as I'm talking here, let's pause for a second. What are the things you should definitely ask with someone with eye problems? Is it painful? Do they wear contacts? Is it affecting their vision?
Do they wear glasses?
Do they wear glasses?
Do you have any allergies, history of allergies?
Allergies? headache, medications.
They have a sensation of dryness or constant teary eyes.
Right. So this is building your HP. Right? Okay. Teaching us. See how this is deeper, this redness? I know it's hard to visualize on this picture, but it's a deeper redness, but commonly confused for conjunctivitis. All right, retina disorders. This is so fun, because you can't see the retina. This is so odd. Okay, macula, okay? The macula. I'm going to try to find this at some point. This gives us our color vision. Okay, color vision. It also gives her our central vision. Our fine acuity. See, optic disc. You guys know what the optic disc is? What the optic nerve is? Optic nerve in the back of the eye. Okay. This is not what it looks like, and you'll never see this. But if you had a panoptic, you could kind of see something like that. So this is, you'll never see this either. But this is what you'll see with a panoptic, about half of this. But see this dark spot? That's the macula. Okay? If you can see a little whiter spot or less black spot, that's the fova. That's our visual, real fine detail that we can see. And this is our optic nerve, this whole thing. We're going to talk about some diseases of the retina, the macula. Are you guys okay